Welcome to everyone that is joining. We're going to go ahead and we have a pretty packed agenda today. So we're going to go ahead and kick this conversation off. For those of you that are new, my name is Wes Adams. I'm a senior director with the Health Management Academy. We're welcomed by a very esteemed group of market leaders on the health system and the industry side today, specifically to talk about the topic of discussion today, which is Beyond Digital Front Door, how health systems are building an access-driven enterprise. Before we get into the discussion, a couple of notes. This webinar is part of our virtual session series, which showcases thought leadership of industry member organizations and their innovative collaborations with health systems. Our speakers are eager to get the conversation started, but before we get going today, a couple of brief housekeeping items. We're recording today's session, and that's including the Q&A that you'll be submitting. Should anyone want to ask a question, please submit through the Q&A feature throughout the session. No need to wait till the end. We will collate the questions and share them with the panelists, and then we'll also have those in follow-up after the session today. So if we can't get to your questions today, we'll make sure to answer them in follow-up. And then towards the end of the session, we'll launch a brief feedback survey. It'll be about 10 minutes left in the discussion, so keep an eye out for it. We'd be grateful for your input, so we can make sure that we integrate your feedback and we improve this webinar series on a continuous basis. But with that said, let's go ahead and introduce our speakers for today. So again, my name is Wes Adams. I lead the research over at the Health Management Academy, and my partner from a moderating perspective is Steve Nilsson, who's the Managing Director of Access and Experience at Tegria. Later in this discussion, we'll feature a panel of health system leaders, and we'll save their formal introductions to when we start the panel in about 10 minutes. But we're welcomed today by Haley Bolin, who's the VP of Access Performance Management at Emory Healthcare, as well as Jeremy Rogers, the VP of Digital Marketing and Experience at IU Health, and also Andrew Smith, the VP for Patient Access at Sutter Health. Now, before we get to the panel, I want to just give a brief introduction to the purpose of today. For those of you that don't know, Tegria and the Health Management Academy partnered in 2025 to dive back into how systems are redefining and restructuring their access strategies in 2026 and beyond, especially given all of the market headwinds and factors that have been hitting the health system market in particular over the last couple of years. In that process, we conducted a series of interviews as well as a survey across a wide array of executive cohorts to get an idea for how systems were redefining access for their organization, as well as how they were measuring it, and probably more importantly, where the key execution gaps were, as well as the market barriers influencing those execution gaps. And today, we're going to do a brief overview of what we learned from that report, but more so to prop up our discussion of our panel discussion later today. So really quickly, let me go through some of the top line data points from this report. Now, everyone in audience will receive this report in follow-up, so you'll have a chance to dive a little bit deeper into the data. But from a summary perspective, we learned in this study that naturally, access has evolved from an operational outcome to a more core enterprise priority. And of course, that's influenced by a lot of the financial and operational and demand side pressures that we're seeing in the market today. 82% say access is a strategic pillar for their system. 93% are reporting on access KPIs or metrics to their board, at least on a quarterly basis. So access is a priority alongside other strategic pillars, if not the overarching priority. But what separates access from other priorities, perhaps, is that it has to wear a lot of different hats for a lot of different executives. Systems look for access to improve patient experience. They also look to it as a means to improve operational efficiency, as well as a means to provide financial sustainability to their system. And it's in this dynamic of access that makes it a difficult priority to govern and to align executives around when you go to actually deploy the strategy. And what we also know is that access strategy involves a whole slew of different executives across the C-suite, both in how it's developed as well as how it's deployed and operationalized. And kind of if we drill down a little bit further on this data, we see that certain executive cohorts, particularly finance and strategy, see an expected drop-off in that operationalization of access strategy. And of course, we're not saying these executives are operators, but we do think that this lack of involvement of different executive cohorts in the actual deployment of strategy leads to a lot of the misalignment that we see in practice, as well as the lack of ROI and return validation from these access investments. So overarching, access from our systems, high priority, covers a lot of different bases, and can be a point of concern from an executive alignment perspective. Now, when we look into where systems are investing in access points overall, we see that digitally enabled care, telehealth, asynchronous platforms, etc., are still the highest ranking areas of investment or opportunity for improving access at top health systems. We also see, though, a strong interest in investing in other core assets, both ambulatory, outpatient, as well as inpatient flagship. So, pretty strong interest in continuing investments across ASCs, non-surgical ambulatory footprint, hospital outpatient surgical care, hospital inpatient care, etc. What we do see a noticeable drop-off in is obviously in the home-based acute and the post-acute and SNF landscape, which is a different discussion that we won't cover today, but it is an important trend that we need to keep an eye on. What we are going to cover today is actually drilling down into the top bucket here, the digitally enabled care. So when we asked executives, what part of digitally enabled care are you really investing in? We see a strong proclivity to reinvesting in core platforms and core capabilities, maybe more so than bringing in new capabilities. So majority of systems indicated they're improving their investments in telehealth and virtual care platforms, and centralizing scheduling systems and digital navigation tools. And this reinforces this notion that maybe the market is at a point of maturity where it's not a notion of new capability, but really building the infrastructure to sustain access digitally. Now, when we look on the other side, what are the top barriers to success? We see that a lot of the top areas of investment are also met by some of the top barriers to success in those investments. So capacity is still the number one challenge to access strategy today, as well as even scheduling and navigation processes and infrastructure, as well as digital front door. I think what this shows us overall, and this is something that we picked up in our conversations with executives, is that access moving forward isn't necessarily a new tech problem. Of course, there will always be new technology to help augment current efforts, but it really is an infrastructural and operational problem. I think we see a lot of systems over the last couple of years investing in a very top of funnel approach without necessarily the same level of attention in mid funnel and bottom of funnel operational capacity to sustain that access. And that's what we're getting here in the data today. And this is underpinned by a slew of different market barriers, notably staffing shortages and limitation, as well as financial constraints, but also evenly distributed across our health system cohorts. Technology integration challenges, legacy infrastructure challenges, leadership misalignment or lack of ownership challenges that stems to, again, how access is defined broadly across the system, as well as competing organizational priorities. So a matrix of issues that, again, are less new tech oriented and more infrastructural. And what we learned in this process, especially given current market headwinds, is that CFOs themselves are becoming much more stringent and focused on immediate ROI that they're getting from their access investments. And so in our discussions with CFOs, we learned that we're seeing their movement on the risk aversion spectrum moving a little bit towards being more risk averse and only investing in digital or access investments that have a clear attributable margin impact, that don't require 2, 3, 4 steps to ROI actualization and that are measurable. And so we are starting to see, again, a little bit of the patience dip in terms of return on investment actualization and that time window for access investments. And that's stemming from, again, kind of failure of previous investments as well as where the market is today. Overall, what we learned in the study, and again, you all received the report in follow-up, so please take some time to look through all the different data points. But what we learned is there's 3 overarching barriers that are impeding access strategy today for health systems. Number 1, a governance gap, where the level of prioritization doesn't necessarily equal the alignment across the executive C-suite or executive owners around access. Number 2, even when that alignment is established, strategy does not always equal the operational realities of the system. And number 3, even with that operationalization, that investment does not always equal validated financial return for the system. And so today, what we're going to do is use the panel, our panelists today, as well as Steve, who's going to moderate the panel, to really dive into how these different access leaders have been able to tackle or are currently tackling these challenges today as they're improving their system's enterprise access strategy. So, on that note, let me stop sharing. I'm going to go ahead and pass the mic over to Steve Nilsson. Steve, do you want to just quickly introduce yourself and then we'll move into some of our panelist introductions?
Yeah, thank you, Wes. So Steve Nilsson, I work here at Tegria. If you're not familiar, Tegria is a healthcare consulting firm working exclusively in the healthcare space. And my team, the Access and Experience team, works with leaders such as those on the panel to help them solve and execute all the things within their strategic vision when it comes to access. With that, I think we can do quick introductions. So, want to start with Haley?
Hi, good afternoon, everyone. I'm Haley Bolton. I serve as Vice President of Access Performance Management at Emory Healthcare. We are an academic medical center based out of Atlanta, Georgia, and excited to talk with you all today.
Thank you, Haley. Andrew?
Yeah, hey there, Andrew Smith. I'm the Vice President for Patient Access at Sutter Health. We are a not-for-profit system in Northern California, and as part of my role, I help with our strategies for scheduling and referrals and just generally improving the patient experience when trying to access care.
And Jeremy.
Hi, everyone. Jeremy Rogers. I lead digital marketing and experience at IU Health, 16 hospitals here in central Indiana, academic medical center. I've been with the system for just over 10 years, and a lot of our work touches on digital engagement with consumers and patients, which is so heavily centered on access these days.
Thank you, Jeremy. So like Wes, I have been looking at this data for the last couple of months and diving into it, trying to understand it. And I'm really excited about today because we're going to move past, what are we seeing from a barrier standpoint and actually get into real life examples of how people are executing their access strategies and hear about some successes from our panelists. So what we're going to do is start with going around the room and just hearing at a high level what's happening at their organizations. And so we'll be looking to hear about both the challenge that they're trying to solve and then the solution they've implemented, the results they've seen, any key takeaways they've gotten from those initiatives. And then from there, we'll drill down specifically into each of those barriers that Wes mentioned on his last slide. So with that, Haley, I'm going to start with you. And it's my understanding that you guys have done quite a bit of work in looking to create sustainable, standardized access practices across your organization, and would love to hear more about that.
Yeah, thanks so much. I've been in access for about 12 years here now, and I would say it looks markedly different than it did when I began my career. I think from, a high level, we're sitting in a different space than we did even a few years ago. We're with CFOs talking about margins. We're in growth planning sessions talking about market capture. We're in quality conversations talking about care gaps. And I think access has really earned a seat at the table to help shape and inform decisions. And a lot of that began in 2023 when we launched Emory Now, which operated at the intersection of several different compounding pressures that likely feel familiar to many of you. We had moved on to Epic as a new EMR in October of 2022, which was undertaking under the shadow of the remnants of COVID-19. And so a completely virtual install. And with that, we had some, I think, opportunities to better find our footing and how we were using Epic. We had chosen not to turn on online scheduling at Go Live. I think a result of a lot of pressures leading into our activation. And then we were navigating volume recovery post-COVID. I'm sure many of you were as well. And outside of those unique opportunities, I think we also were navigating a new executive leader who had arrived with a very high bar for access. Our leader had come from the Northeast, where I think wait times were a frontline competitive metric. And with that perspective came urgency and organizational backing to move quickly. And so as we sat at a system level function, we had good enterprise visibility and reach. And in response to a lot of feedback from our board, from our faculty, from our community, and frankly, with, again, alignment and support from our executive leader, we organized a 3-month sprint. And I will say with great affection for my team, it's a wonderful way to build trauma bonds and a little bit of shared PTSD. But we kicked it off with an all-hands summit of more than 250 people across Emory. These were chairs, they were advanced practice provider leaders, they were chiefs, they were administrators, and we charged them collectively with a mission we made a public commitment that we would have access today or tomorrow, which was completely different from the way our templates and access ecosystem looked in that moment. And we were asking them within 90 days to be able to find a reasonable, responsible, clinically appropriate way to create same day and next day capacity. Appreciating often that our providers want extensive medical records to offer the best clinical judgment and guidance, we were really challenging them with how they could find a way to say yes to the patient. Again, appreciating in our market, which looks markedly different from the Northeast or Chicago, right, or other groups that have a ton of AMCs, or Houston, we were competing with local health systems that compete on access. And so our request was to consider overbooks on direct provider schedules at a dedicated time, or using Epic's no-show predictive model, or a shared doc of the day model, or dedicated same-day or urgent slots. So what we required was a what, but the how was theirs to inform and own at the specialty level. I think it's really important to say that we had weekly meetings with often the chair, a physician champion, an APP champion, and then members of every specialty's administrative team. And so we had 34 meetings every week, but we also had monthly executive check-ins with visible progress tracking against clear goals, so very visible red or green. And when teams know that they're standing in front of senior leaders in 30 days with numbers that either reflect success or, right, continued opportunity, I think the work took on a very different weight. So at a whole, Emory now did what we hoped it would do. I think it taught us that urgency creates movement, but I think we also learned that infrastructure creates permanence. And so when the sprint ended, some old patterns had gravity and crept back in. I think we learned that behavior changes under pressure, but culture does not. And so if we wanted our access to be reliable, right, and dependable, we needed a longer term strategy, which is really the work we're doing now. Emory Now is a sprint with a finish line. We've since launched Emory Aspire. We wanted to be aware that when urgency disappears, we need infrastructure to respond and always be there. And so we now have monthly meetings with each of our departments and service lines, essentially a continuation, but with, I think, in a hope of changing our culture through data literacy programs so that people understand and know how to use reports with waterfalls and cascades of what information to look at. That Access is helping bring in IT and digital resources around workflows and changes to referral orders, that we're engaging our facility team to help with physical capacity constraints. We're talking with APPs and nurses around new care models. So really making sure that we are building and addressing all of the friction points and barriers that exist. And from a results standpoint, I think the data has been meaningful for us. From when we started this, we've moved our new patient mix from 19% to 21.5, which can sound modest, but when you consider new patients across the system, net new relationships and downstream utilization, sustainable growth, I think it has been meaningful for us, especially on the imaging side. Our new patients seen within 10 days went from 42% to 50.4, which is a fundamentally different patient experience to have over half of our new patients seen within 10 days. We know that we are helping reduce that sort of emotional motion sickness between I called in, I booked an appointment, and I was seen. And then our realized utilization went from about 64% to 84%, which is filling capacity. It is, I think, better use of our providers' time. It has certainly shown up again from a margin standpoint, from a volume and revenue standpoint, and I think is probably the clearest proof we have that the infrastructure we're building is working. And then I know my colleagues on the panel will get into some of the online scheduling, but we've turned on self-scheduling and have seen about 7% of our activity booked online. And I think that is a clear opportunity for us. Digital access is where patient expectations are moving, and we're building towards that with intention. So my takeaways to close out would be that urgency is a tool, not a strategy. Emory Now worked because it was time-bound, it was visible, and it was accountable, but a sprint is only valuable if something durable and sustainable follows. So know you're sprinting, but also make sure that you are pacing and that you are preparing for really what is a journey. Alignment needs to be applied in practice, monthly executive check-ins, shared accountability, public commitment, I think, really helped us turn executive prioritization into actual execution. Saying access matters and then governing it are two different things. And then lastly, I think you cannot do this work alone if you are a leader in an access space. You really have to build partnerships with clinical leaders, with operational leaders, with finance, with digital, and find ways to reach across boundaries. The closer access sits to operational core, to finance, I think the more effectively the work gets done.
Thank you, Haley. You offered so much to dive into, and it's hard to pinpoint one or two things I liked because I like so much of what you said. But there are two things I wanna highlight. One is the sprint methodology. I feel is a tool that is so useful when applied correctly, and it's a tool we don't use enough in the industry. So highly recommend those of you that aren't using that tool to think about how can you use that tool um, within your organizations. And it is a tool, so it has to be used at the right time. But it is a great tool. The other thing you mentioned that stood out and I think helps us transition to the question I want to ask Andrew is you talked about how changing behavior doesn't change culture. And I know Andrew at Sutter, you've done a lot of work around trying to build a culture of access, specifically with some of the work you guys have been doing with self-scheduling practices and integrated referral processes. So would love to hear more about that from you.
Yeah, thanks, Steve. For those not aware of Sutter, they've had a long history in Northern California. And so for our challenge really was how do we begin to operate truly as an integrated system with consistency across our locations? The patients know what to expect from us. That was not the way we were operating prior to 2023. Around that time, we had the arrival of an entirely new leadership team. And with that came new expectations, really focused on the consumer experience. And so with that, there was a real challenge to, especially, right in the back door of Silicon Valley, consumer expectations for digital scheduling in particular were just off the charts, and we were failing at those expectations. So we really set out at the end of 2023 and into early 2024 to lead in access and specifically with digital consumer access. So we started from a really a goal of online scheduling. It was roughly 10% of our total volume at the beginning of 2024, which already is ahead of where some organizations are. But we felt that we could do much better than that. So the other challenge we faced in our organization is in the state of California, we can't directly employ the physicians. And so we have affiliated medical groups. There's 8 of those, and I'll talk more about that probably later on. But the amount of influence that we have to lead with is pretty incredible. So had to work very closely with our executive team, specifically a new physician strategy cabinet that our CEO stood up along with the medical groups, board chairs and presidents. And in mid 2024, we went to that physician strategy cabinet with a pretty bold plan to essentially uh, redesign all of our primary care schedules within about a 90-day sprint, with the goal being that at the end of that, 100% of our PCPs would participate in both new and established online scheduling. We also got that group to approve for our specialists that they would all participate in return visit scheduling. And so, as you can imagine, this was a pretty bold decision to make, one that many organizations had not sort of led with. And instead, they tend to try to fix the foundation first, then make those significant investments in online scheduling. So, we really looked at it backwards. We saw online scheduling as a catalyst to do the foundational work that needed to be done. So we got that physician strategy cabinet to make that decision, really setting the expectation for participation in online scheduling. From there, my team got very busy optimizing the schedules of those clinicians. And today, here in early 2026, we've surpassed far beyond primary care. We've updated over 5,500 individual clinician schedule templates over that time period. We've begun decision tree build, and really, we've been fixing that foundation in the background, but we started with online scheduling. So our results to date, we're really, really proud of. In January this year, we've had over 30% of our total appointments made online. In primary care, that number's above 50%. And in our specialty clinics, it's around 15. So we see a real opportunity to continue to push on our specialty practices, to open up their schedules and to make their inventory available to patients. But it's also driving more of that foundational work to be done, decision trees, schedule templates, referrals, which has also now led us to another endeavor, which is centralizing our referral scheduling for the organization. By the end of this year, we'll have centralized referral navigation for the entire organization. And that'll cover about 2.2 million referrals a year coming through our team. So if it gives you kind of a sense of the scale that we're working with within our organization. So I think really for us, the results have happened, as a result of those bold decisions, really driving culture. And I'll talk more about that, I think, in some of the other questions that come up. But I think really it's access is a strategic decision. It's not, as you mentioned, Wes, it's not a technical one. The technology exists to do this well. It's really culturally, are we willing to put consumers first and make bold choices to really give them an experience like they get in so many other aspects of their life. And then I think the other one was just the culture followed clarity from our leadership team, our executives, our CEO in particular, setting this is an expectation for us as an organization. Like Haley mentioned, they're kind of unique in their market. Well, so are we. We're actually surrounded by academics, whether it's Stanford or UCSF. So for us, we actually had a really big opportunity to differentiate based on access. And so setting that expectation with clarity really allowed us to kind of, it sort of paved the way for us to move quickly through the organization. But creating that alignment with our medical groups has been key. And so I think that's the last of the takeaways is building those partnerships, especially with physician leaders. A lot of times we talk about executives that live sort of in administrative roles. Executives within our medical groups have also been incredibly instrumental. So I think those lessons apply probably to most organizations, whether you have employment models or not. But I think certainly can deep dive on some of those here later on in the discussion as well.
Thanks, Andrew. Jeremy, I saw your head nodding quite a bit when Andrew was talking, and I think you have a lot of thoughts on what he was saying. Would love to hear from you, the work that's being done at IU, and I know some of it is about balancing those consumer expectations with really the reality of what we can do operationally and what our capacities are within the health organization. So we just love to hear your thoughts, what you guys are doing on those fronts.
Yeah, spot on, Steve. And I'll say it's tough to go after Haley and Andrew because so much of what they said resonates. I mean, I could copy and paste a lot of that. Very, very similar journey we've been on here. I joined IU Health about a decade ago. And back then, think about 10 years ago, at that point, it was still fairly novel to offer open scheduling on a website or a portal, okay? That is no longer novel. I mean, even back before the pandemic, that became table stakes. But I think so many of us, whether it was the technology or the operational capability, we just couldn't make that the reality. So I think to Andrew's point on like lower acuity, like some of the front door services, we had great strides prior to the pandemic in growing engagement utilization in those areas. But we found where you have the decision support trees, the long algorithmic scheduling, at the time, we just did not have the capability or the standardization to make that a reality. So we quickly learned it was not a one size fits all approach. You have to really be pragmatic around that. That was a key learning for us. We're in a unique spot right now because we're in the middle of our current Epic transformation. It's public. We're going live on Epic next year. So we're late to the game compared to many of you. What we're doing though is learning from all those like bruises and bumps that we experienced over the years and maybe not replicating those in our new environment. In the past, in our current state, I should say, we've had to do a lot of bolt-on. With that bolt-on approach, it allowed us to add new capabilities, but it created challenges for our teams around having that consistent experience. I mean, patients are expecting, whether they're on the phone, on a portal, on a mobile app, to be able to surface the same information, same data, same slots, things like that. That became very, very challenging. So I think that's we look forward. That's a key component. And then I think to Wes's point in the tee-up, we learned a lot around top of funnel versus mid funnel. It's not about just getting that first appointment. It's about continuity of care. It's about care coordination. Frankly, who cares if you can get a patient in for the first appointment if they can't get a diagnostic or referral or the follow-up at the right time with the right provider? are you really serving them best? And that's been a painful lesson for many of us. Again, I would challenge you, access is not just about getting the first appointment. It's about providing care across the full continuity. That's been a big, big deal for us. And then also to Wes's point, this is not about tech anymore. We have tech for this coming out of our ears. It's about culture. It's about change management. So I could go on and on, Steve. That's my brief take on all of it.
No, and it's great, and I share a lot of your same views, and experience is part of what myself and my team does, and I can't agree more that it's not just about the one appointment; it's about all the appointments that happen, and being consistent on how people navigate through your system is a huge part of experience. Setting those expectations on this is what it's like to be part of IU or Sutter or Emory, right? And establishing knowing that culture for your staff, your providers, your team members, but establishing that culture for your patients is a big part of it as well, in my opinion. Um, with that, we do have one question for Haley, and then we'll move on to our next topic. But the question is, what types of changes were made to the physician provider templates to optimize templates and improve access? And then what metrics are you using to measure template utilization? And after Haley goes, I think Andrew or Jeremy, if you have a comment, feel free to weigh in as well.
Yeah, I would say given the opportunity, I think, to revisit a lot of the decisions we made ahead of Epic, we had an opportunity to try to have more open scheduling. So I think some of the things we leverage as part of Emory now is more of session limits, right? An open time, making sure that if we had built blocks or dedicated new patient slots, that we were opening those up. Again, I think just maximum flexibility would probably be the highest level answer. From a utilization standpoint, I think we focused on our no-shows and our late cancellations quite a bit. So making sure for Epic clients, Fast Pass from an automated wait list was a really critical part. Changing the time for when we sent them, adding more times throughout the day, and making sure really almost every visit type was included as an option in every provider. But I would say, also a critical part of template optimization was going through and assessing our durations and doing time studies, using things like our video client to say how much time are we spending in a virtual appointment? Does that match the reality of the day? I think a lot of our planning for Epic was worst case scenario for visit duration, right? 60 minutes because the most complex patient might arrive. And then being able to leverage data, again, collected on the ground, but also through Epic to highlight where we see we could perhaps adjust and decrease and get to the 80% of patients. And so a lot of work also around follow-up orders. I can spend a ton of time on this, but I would say there's a lot around template optimization that has included use of care teams, use of follow-up orders, really flexible schedules as opposed to overly prescriptive, rigid schedules. And then with our data, we look at, again, our block fill rates, our overall scheduling utilization, our no-shows, our late cancels, our left without being seen. And then I would say more recently looking at patient journeys, their movements across our system, referrals generated, imaging orders generated, patients follow through and fulfillment of those orders have been recent data points that I think have also helped us understand experience tied to access tied to templates.
Excellent. Andrew or Jeremy, you want to add anything?
I'll add just a couple others. I agree with everything Haley just mentioned. We probably have an entire library of metrics like many of you do. But two others that I would offer that we're looking at really kind of around that digital experience again. One is we're looking at the percentage of appointments that were made without having to bypass a warning of some kind. So are we fully leveraging Epic automation to find the inventory that we've created in our schedules? We found that there's just far too much manual activity needed for our schedulers. And so we've made it easier not only for our contact center, but also for patients who are going online by doing that. We have kind of a saying within our team is just relentlessly eliminating friction. So if it can't be automatically scheduled, there's something wrong that we need to go fix so that we're not creating some of these self-inflicted barriers to scheduling. The other one, in addition to warnings, is just a percentage of our capacity that could have been scheduled online. So this is something we have to look at sort of retroactively, but for every appointment that is scheduled, we have a report that says, could this appointment have been booked online? Yes or no? And so that's actually for us a leading indicator to whether we're going to drive more online scheduling. We've seen that if an appointment slot is schedulable online, about 90% of the time it's filled online. So it's basically you build it and patients will find it. So that's another metric we've used, and we're finding a lot of success in using that.
Great. Thank you.
And Steve, I would just add one thing there. We've looked at over the years day parting, so comparing like what time of day patients are scheduling, because you would think logically more self-scheduling in the evenings or weekends. Actually, in many cases, that's not the case. They're oftentimes scheduling during business hours, and so just trying to look at trends, which has been very interesting over the years.
Yeah, and a lot of my background comes from call centers and things like that, and you do a lot of that as well in call centers, and comparing that data to the online scheduling is actually very interesting to me too, to see is it where the difference is and things like that. Um, Taking us back to the report and thinking about those barriers that Wes mentioned at the end of his slide, I want to hear from you guys on how you've approached those specific barriers in the situations that you've given us as examples. And Haley, we'll start with you. And the first barrier we're talking about here is that executive prioritization doesn't equal alignment. Right? Just because we go and we say, "This is what we wanna do," or "This is what we're doing," doesn't mean it goes all the way up and down to everybody, and everybody fully understands what it is and understands what their piece of it is. So with that, like, what key obstacles did you navigate in this space? How did you ensure that executive alignment around goals and governance, long term?
Yeah, I appreciate the question. I would say I think it's fair to say for academic health systems that what makes them extraordinary, the depth of expertise, the strength of individual domain authority, right, also makes it genuinely complicated and complex to navigate because there's such a richness of competing priorities. So I think at the heart of it is access can be a strategic priority, but it can be one among dozens and many. And I mean that and truly as a compliment, there's a ton of exciting work that we're chasing down. And so I found often we're dealing not with resistance, but frankly, I think leaders, physicians, right, operators who are working in earnest to try to figure out how they can accomplish everything and need support. I think Emory Now was a nice opportunity for us to highlight not that access is important, but here are the tools, here is the support, here's the dedicated time. The template decisions, the governance, the capacity was truly protected. So really appreciated the comment, right? Tracking warnings, tracking capacity that we built online. The preservation of the intention of the schedule is probably something I could have offered. In my earlier comments, we're not only looking at our new patient mix and what was realized, but also did we ever build enough new patient capacity to be successful in matching the goals that we've set and the demand that we expect from our community. So I think the structure has been a really intentional organizational act, that there is executive weight, but that there is cross-functional mission with shared accountability. And the accountability for us with our sprint started by everyone being in the room and everyone hearing the same charge, telling real patient stories, highlighting our market share and our landscape, talking candidly about our financial performance. So there were numbers, there were humans, right? And then there was visible tracking that went all the way up to the top. And I think the template then that hasn't been touched in 4 years becomes worth revisiting. And then I would highlight that we have worked as an organization to simplify our priorities so that we don't have as many that feel like they're competing, and that we've really worked to create more visible and simplistic dashboards, incentives, compensation models that again thread this in a way that everyone feels like access is important, not just as an access metric, but it is safety and quality from a delayed diagnosis standpoint. It is branding and experience, right? Patients can go somewhere else if they're displeased with the entire experience. Um, and it is certainly financial from a margin standpoint. I think framing access through the patient at the center of it, but contextualized through financial data, through experience data, through safety and quality data helps the message land differently.
Yeah, I think so many of those ring true, and I like that you're bringing up data, and that actually going to bring us to one of our questions that we're going to talk about later. One thing you said that resonated with me was getting people to understand it's not a gotcha kind of moment, right? It's this is what's happening, right? And we need to move forward. And um, Andrew, I think that I think that translates to your culture of access, right? In a true culture of access, we don't have these gotcha moments. The numbers are what they are, and we need to move forward together. Um, in your efforts, how have you been able to drive that alignment, and create those winning situations?
Yeah, I couldn't agree more. I mean, there's probably a few things that they sort of sound cliche, but a few sayings that we've implemented that have really started to take root across the organization. The first is, in any of our large system events where we're presenting access, we have a very consistent win-win message, which is that we are looking to reduce the administrative burden on our teams to see patients and deliver care. And in doing so, we're also eliminating that friction that our patients experience. And so when we keep that win-win front of mind every time we're in front of the organization, I think that's helped. We've also done some other things that have signaled to the organization that it's not just talk. We hired a CMO for patient access that serves as my dyad partner. She's an OB physician by training. She's also the chair of our women's health service line now. But for me to have a physician that can stand side by side, delivering the messages about what we're doing and why, I think it builds some of that credibility with the physicians. And then credit to her, she actually kind of helped coin this phrase, but we talk a lot about, the flexibility within the framework we've created. So we've defined guardrails for how we're going to build schedules. We've set really clear goals that we're going to work towards, but we leave some flexibility for autonomous decision making as well. Not every orthopedic surgeon is going to be able to see patients in the same amount of time. Each of our 8 medical groups has slightly different flavors for how they monitor productivity and things like that. So we've allowed some of that flexibility to remain and let people feel some buy-in that it's not just this top-down strategy, but we've been really clear that we still have to get the results we're after. And I think reinforcing that through goals has been the other thing. Before our CEO started, I think there was something like 22 separate annual incentive plans throughout the organization that got quickly aligned to one. And so everyone now has, again, clarity about what are the access goals we're working towards. Where do I then have the flexibility to achieve the goal through, again, local decision making? And again, keeping that win-win in mind. So I think those to me are the 3 big things we've done to create that alignment.
That's great. Jeremy, when we move to you, I want, if you can, speak to this, what I call priority fog that happens with competing priorities. And we see it at all levels. But when we have so many things we're trying to do, it's hard to know which one to work on and hard to understand how one is affecting another. And how do we make sure that all the decisions we're making are truly moving us in that one true north direction? So tell us how you navigate that and how you work with your peers on making sure that priority fog doesn't get in the way of execution.
No doubt, Steve. I think many of us are in very change-rich environments now. We have lots of competing priorities. So I think it's all about alignment, like Haley mentioned earlier, like collaboration, alignment, getting people to really view access as kind of an underpinning or a foundational enabler for all of our corporate strategies. That's kind of the first step there. We've put a lot of emphasis on infusing the voice of the patient. I think many of you know patients don't use the word access, but they talk about delays, they talk about wait times, they talk about barriers to care. Using those stories, like we've done a lot of our own primary research, getting patients on video, telling their experiences, good, bad, or indifferent, playing those videos in a room of executives, it's hard to argue with that. So that drives alignment very quickly. And then from there, it's the trade-off decisions, the prioritization. We can't do everything. There are opportunity costs, but if we bubble up those things that matter most, that's the approach that's worked well for us.
I do want to do a quick time check, and we're getting close, and I think we could probably talk about this all day. I know I could. I don't know if that says about me, but I find it vastly interesting. There's 2 more barriers that we wanted to get to. One is that strategy doesn't equal execution, and then also we wanted to touch on investment doesn't equal ROI, right? Both are very important. And I think we can maybe talk about those together. So as we move through this next question, I ask that you guys think about it as maybe answering both of looking at, you know, how do you take that strategy and actually make sure we're executing on the strategy we want? And then how are we defining success of that strategy in terms of ROI? And I know a lot of times, the people writing the checks want to see those in dollars, but it doesn't always have to be in dollars. Although if we can, it does help our cause and access to get more investment. So with that, Jeremy, I'm going to go back to you and would love to just kind of hear how IU has been looking over at that over the last few years. What have you learned in the process? And really, what are maybe some of the keys you're seeing in getting strategy to execution and how you guys are measuring that after the fact?
Yeah, Steve, I think we've learned a lot. I think to echo some of the comments earlier, when speaking of self-scheduling, just having the technical capability doesn't do you any good if there's no capacity downstream. Like if you just turn on the technology, I mentioned earlier, one size fits all doesn't work. You've got to be very specific on what are the appropriate KPIs, the appropriate benchmarks by specialty, by service line. That was a key learning. And then some of the downstream constraints, I mentioned things like referral management or orders or prior authorization. All of those things accumulate and it contribute to the experience both for the patient and our care teams. You have to take those into consideration. I think the question about ROI, we're all challenged now to defend ROI, to put a flag in the ground. We've done a lot of work with the investments we've made over the years to go back and do multi-year look backs. So if we built a business case around an investment, we made some expectations, we made some assumed benefits. Did we realize those benefits? In many cases, the answer is yes, but there may have been unexpected factors. There may have been things like, pandemics that happened that nobody predicted. You've got to go back and kind of revisit, were those assumptions accurate? How did they play out in the real world? When you face the battlefield, did they actually end up as you expected? Look at those. And like I mentioned, our Epic journey, take those key learnings and drive them forward. Like that's water under the bridge. But if you're learning from those past observations, past data points, it makes better decision making going forward. That's been a key piece for us. So you gotta fail forward basically. Like it's okay to make a mistake, but how do you improve from it and not keep falling down repeatedly? That's what I would say there. Key learnings.
Yeah. No, key learnings are so important. And you brought up a couple of points I don't know that we touched on a whole lot yet, but there's so many things out of our control, right? And we need to react to them. And even though we might have a really great 5-year plan, the odds of executing that 5-year plan exactly how we laid it out are pretty slim because we're going to have to navigate and adjust and take those exactly what you're saying, the learnings, and pivot when necessary. Another reason why things like the sprints and stuff like that I like too, right? Because those are shorter term and we can adjust quickly. Um, Jeremy, I want to move to you and hear about more about your culture of access, and specifically some of the things you already mentioned was change management, and things like that. And how does that really get us to, you know, executing that strategy and showing that ROI at the end?
Sure. Yeah, I mentioned a lot of those foundational items at the beginning. Having to update schedules, really leverage Epic automation. I think for us, it was, we could have spent a long time executing on template optimization and doing all these things to then get it right before we made the choice to enable online. By going backwards, we really looked again, that was the catalyst for us that we were going to make this big transformational change for our patients, and in doing so, it was the catalyst to do some of that foundational work that otherwise probably would have taken much longer. And we would have been caught in the kind of consensus building trap that I know many of you probably face when doing that similar work. So for us, again, kind of thinking about it backwards was really the execution pathway we took. When we start to see the ROI on this, though, we've looked at it from a few different ways. One, obviously, is you optimize capacity, there's more throughput. We're also seeing results, though, in other areas. So, for example, our enterprise contact center answered about 6% more phone calls last year, but they didn't have to add any staff to do that. And it's because we've made their workflows more efficient. We also obviously online scheduling means that we, again, need fewer call center agents to schedule appointments. So there's savings for us to be more efficient as an organization that we've seen demonstrated through this. Referral navigation, same thing. By centralizing scheduling, we've seen conversion of appointments go up. They've scheduled 12% more appointments coming from referrals in our Sacramento division last year. So there are really tangible results. The other one that we're looking at, and I think this is maybe partially because of where we sit in the organization. We're part of our consumer and brand division. So we are looking really closely at how does the work we're doing translate into our brand. Um, One of the ways we're measuring that is the percentage of patients who see us for more than one thing in the system. Last year, about a third of our patients saw us just for primary care. We think that that really represents a huge opportunity to see patients for more specialty care, more ancillary services, and so forth. So we've actually set that as a target this year to reach closer to 50% of patients seeing us for more than one thing. We're also seeing this through our brand tracker data, where over the last 12 months, we've actually seen our Sutter brand emerge to the top of the pack in our market. We're seeing other organizations like the Stanfords, the UCSFs, the Kaisers actually start to decline. And so we're actually seeing that as we're taking share of care now because of the work we're doing to streamline access to care for our patients. So we're really, really excited about that. I think that brand, that loyalty is definitely something that has significant ROI attached to it.
Yeah. Thanks, Andrew. Haley, to wrap us up, I would love to hear if you could make some comments on how organizations can really be more realistic about setting their expectations when it comes to access strategy, given the hurdles and the barriers that they have to fight through. And if you have some ROI to tie that into, that'd be amazing.
Yeah, I'll work to be brief. So if anybody wants to connect after, happy to spend more time like you, Steve. I could spend all day on it. I think that's been a really, really critical and core part of our conversation with Emory Now and Emory Aspire. I think Andrew might have said it, but I love a lot of our focus has been how do we put back more joy into practice, but also into daily operations and management. And so everything has been on the table from we don't like our break room or we don't have good leave to our compensation and incentive packages need to be revisited. And so I think a lot of our work has been, frankly, understanding all of the friction points and barriers that exist from recruitment and credentialing, right, to when the bill goes out at the end of the visit or the order is placed, and then working in earnest to tackle them. And so it has meant partnership with every area within Emory Healthcare. And I think, a lot of that is built upon a shared understanding that the front door has to be frictionless, right? You've heard that from my colleagues. It has to be simple, it has to be digital, it has to be responsive and meeting patients where they are. But the house itself has to be structurally sound, right? Because patients will feel that the moment they step inside. And so the templates, the scheduling infrastructure, I call that my subfloor, my flooring, like it's what everything rests upon from a foundation, and it can't be patched over. And so I think a lot of our work has been coming together. I use that hard hat analogy a lot with my team, but building templates, compensation models, physical space constraints, truly that cannot be overcome on their own, but have to be working in harmony with one another. And so, again, being mindful of time, I would say that feels critically important that you take an honest inventory of what all the friction points are beyond just, right? How does our website function? Is it clear and navigable? Are our phone numbers, are our intake questions patient centric and simple? But how are we also advocating for work RVU differentials that incentivize access-friendly scheduling at night and on weekends? How do we push for unified incentive plans that connect compensation to access performance? And again, how do we minimize the number of metrics that exist so we have a common core focus? And I think from an ROI standpoint, I would say finance really has been essential as a partner for me and my team. They have been helpful from compensation redesign and capital investment, but also really in helping us connect through data how the math is undeniable when we look at our ambulatory work RVUs and our patient volumes. And again, creating co-designed dashboards that highlight the realization of expected time in clinic so that our finance leaders, our chairs, our administrators can see how access performance connects to productivity and revenue. And I think we're really working to surface these gaps in a way that feels very clean and clear. So shared data, honest conversation, I think genuine mutual investment is what a successful access strategy can look like. And again, I would close and ask all of you really to consider a template redesign, governance structures, and dashboards, but that it is this work that will help you not only build the front door, but make sure that the house is worth getting into and worth staying at.
Thank you, Haley. And thank you, Andrew and Jeremy. This was an amazing discussion today. And I'm going to turn it over to Wes in just a second for some housekeeping. But before I do, a couple of closing thoughts from me. Um, I I think you all mentioned it, but it's not a technology issue right now. It's a people and process technology issue that we need to address as an industry, right? And it's more than just processes or saying how we want to do it. It's creating our cultures for our team members, our providers, our patients. Um, Haley, you mentioned a few things in your last statement that we often overlook about, what's it like to be an employee at our organization, and do I want to be there? Not do I like coming to work, and do I have the basics I need? I mean, we don't need to be a startup tech company where we have, pinball in every room, but having access to lunches if we want them to be on site, or having the right technology and things that work are important, right? And they're the basics and the expectations. So with that, thank you again, everybody. This was amazing. Wes, I'll turn it over to you for a few last housekeeping things.
Yeah, and if everyone just digitally, thank you guys so much for joining today and sharing your expertise with our other health system leaders on the line here. Really invaluable. I will say there was a good amount, 3 or 4 questions that we weren't able to get to. And so, Andrew, Haley, Jeremy, Steve, I'll make sure to follow up with you on some of those technical ones so that our audience members have answers to some of their technical bits that they had around your different initiatives. I think it's indicative of how great the conversation was today. But just for everyone to be aware, you will be receiving this recording and follow up. We'll probably be reaching out in the next couple of days, depending on when we're able to get the recording churned out. You'll get the recording as well as the report. And please feel free to use me or Steve as a resource to you in trying to learn more about what we discussed today. And we'll make sure to connect you with the right resources. But panelists, Steve, thank you again for joining. And everyone in the audience, thank you again for joining today and being part of a great discussion.